We are recording now. Well, thank you so much, everyone, for joining us today. We are delighted to have Dr. Avik Chatterjee join us from Boston Medical Center. He is, he will introduce himself, but just to say that there have been so many discussions regarding housing as a social determinant of health when it comes to the overdose crisis. And in the news lately, we've seen a lot of discussion around what is the best approach. Encampment clearings are a hot topic. I mentioned it to you this morning. Don't know if it's part of your talk today, but I know that discussion has definitely happened in Rhode Island as well as Massachusetts and other places. We are just delighted to have you here and to hear about your work, your experiences, your thoughts. And I'm hoping we can leave a good amount of time at the end for discussion as well.
Sure. Well, Drew, thank you so much for the invitation. It's great to see everyone, including some folks that I know already, like Brandon and Gary and other folks that I'm excited to see. I'll spend just a minute introducing myself, and then I'll go through my slides. I did see your email earlier, and I added a slide around encampments, but we can talk more about that as well. My name is Avik Chatterjee. I'm an internal medicine and pediatrics trained physician. I'm also addiction medicine board certified. Just to give you a little background of how I got into this work, I did residency at Yale, and what I was seeing clinically, I realized that while it was really interesting, regardless of what it might be related to overweight and obesity, gun violence, substance use and addiction, I realized that there were bigger factors shaping my patients' lives that I couldn't really fix necessarily in the clinic room. So I ended up doing a Gen Med fellowship. I came to Boston to do that. I was doing research. I was doing a master's of public health. I was doing work on actually childhood nutrition and school food programs. But I was allowed half a day a week of clinical time. And I was like, well, it's only half a day a week, and this is only going to be while I'm in fellowship. So let me find a cool place to work. And I had heard Jim O'Connell speak at a conference, and I thought, well, healthcare for the homeless has a cool reputation. It'll be fun to do for a couple of years. And I started working out, for those of you who know anything about Boston, on Long Island, which is an island in Boston Harbor that had the biggest shelter in New England at the time. And I absolutely fell in love with it. I could go on for a long time, but basically at the end of the year, at the end of the 2-year fellowship, rather than move into a full research role, I said, I love this job, seeing patients in shelters too much. And I took a full-time job at Healthcare for the Homeless. I did that for 4 years. And now Jeff Samet asked me to move over to BMC. So I'm there half-time at BMC doing work on the Healing Community Study and some other projects, but I'm still half-time clinical at Healthcare for the Homeless. Half of that time is at Southampton Street Shelter, which is at the epicenter of the Mass Cass area that you might have heard about, and then half time on the family team. So with that, I'll start my slides, and feel free. It's a smaller group. Feel free to interrupt me. Any questions that you have, and we'll figure stuff out here. All right. I just wanted to thank a bunch of people for help with the slides. I think Jesse Gata, who probably many of you know, I think originally made a lot of these slides, and then I've inserted other slides from other folks as well. I'm going to talk about healthcare for the homeless and our patient population. I'm going to talk about expanding access to medications for our patients, medications for opioid use disorder. I'm going to talk about harm reduction, which for all of you is going to be more of a review than anything else. But I'll talk about SPOT, which I think is a cool and interesting model. And then I'll talk about harm reduction next steps. But at that point, we can also talk about the encampments and what we know about those spaces. So Boston Healthcare for the Homeless was, this is actually a little bit misleading. I keep meaning to change it. My understanding is that Jim O'Connell was there at the beginning when it started, but that a coalition of advocates for people experiencing homelessness sort of got the funding together and made the model. Jim O'Connell, actually, interestingly, he talks famously about this, but was not when he first came into the clinic at Pine Street Inn, he was not allowed to see patients as a doctor. The nurses there said that he needed to wash their feet in the foot clinic for 6 months before they would have the level of trust needed to have him be their doctor. So, and then now because it's been around for so long, and because health insurance coverage in Massachusetts has been so generous for so long, the program has been able to grow and serve a large number of patients, and is one of the biggest programs in the country. The mission is to ensure unconditionally equitable and dignified access to the highest quality healthcare for all individuals and families experiencing homelessness. Just as an aside, Massachusetts is the only right to shelter state for families. There's a whole caveat to that, which we don't have to talk about, but as has been in the news. But because of that, actually more than half of the people experiencing homelessness in Massachusetts are homeless as part of a family with dependent children. So we've had a family team as long as the organization has been around, basically, and I'm happy to serve on that team as well. But a few things. So the model, there are a lot of things that are important about the model. I'll say one important thing is that we provide care to folks just as most FQHCs do, or all FQHCs are supposed to, regardless of ability to pay. Two, that we have consumer involvement. In the case of Healthcare for the Homeless organization, it means a community board that is made up of people who use the healthcare system. And then we meet patients where they are, which we'll talk more about. So we have over 30 clinical sites all across the city, including mobile sites and street outreach sites. And then we try to prioritize what's called one-stop shopping, which is having all of our services available at all times in all places, which is different. This is a list of the services we have, but just to say, we have dental care, addiction medicine, integrated behavioral health, Hep C treatment, HIV treatment and prevention, medical respite, all these different things. But getting closer to our topic now of why this is important for our population. So overdose is a leading cause of death in our patients. We're located near the MassCAS epicenter. Our main building is. Overdoses have been frequent in our main building, which is a point actually that Ju and others of us are looking to explore as far as the technologies that we put into place to try to prevent fatalities from those overdoses. And that we knew that we weren't effectively engaging high-risk people with substance use disorders despite the existing programming. This is an older study, and I keep meaning to replace it with the newer slide. There was a recent study, a recent repeat of this study that came out. But basically, this study by Travis Baggett, who maybe some of you know, and others, was really foundational for what Healthcare for the Homeless is doing now. It basically showed that overdose was the leading cause of death among people seen at Boston Healthcare for the Homeless, and most of those were opioid related. And what was powerful about this study and an important learning point was that wasn't always the case. In the earliest cohort of people that they saw at Healthcare for the Homeless, the leading cause of death were actually infectious disease related. So HIV was a major cause of death, things like influenza or pneumonia, tuberculosis. There are a lot of non-overdose related deaths. And so what you noticed in the cohort basically 2 decades later is that those deaths had gone way down. People weren't dying of HIV and TB and pneumonia nearly as much. And so had that been the only thing that happened, the mortality rates for our patients would have gone down. Instead, though, overdose death rates increased substantially, such that the overall mortality rate, SMRs for our patients, stayed the same. The infectious disease deaths were replaced by overdose deaths. So we are practicing in a context, and the context includes media. And so one thing that happens is and we'll see evidence of this later, but there's a lot of really stigmatizing media. But even I think sometimes media that tries to be, balanced can be problematic. I think I want you all, and Jessie, when she gives a talk with a version of these slides, she draws attention to this picture at the top left, which I think is meant to show a negative aspect of, quote unquote, life on methadone mile. But basically that public drug use is bad. And this is things that people are seeing at MassCAS when they drive by or whatever it is. but I want you all to keep that picture in mind, and we'll come back to it. Approaches. So as you all know, addiction treatment occurs on a continuum, but regardless of where you are on the continuum, acute treatment all the way to outpatient services, outpatient management, there's a role for a certain set of things. One is medications, which we'll talk about first, medications for addiction treatment. Two is the support around social determinants of health and other goals that are outside of sobriety, for example, family, job, housing. And then finally, harm reduction strategies, which we'll talk about as well. These are things that we should make sure are available all across the spectrum. And so we need to recognize the need to expand access to all types of addiction treatment, as well as housing, as well as to recognize in parallel the need to reduce harms associated with drug use for all of our patients. And so we know that we have some addiction treatment availability, but certainly back, let's say in 2013, when I started at Healthcare for the Homeless, we were not engaging people well, and there were a lot of gaps. So expanding medication access. Again, all of this, this is an audience that is very savvy about all of this stuff, but this is a slide that describes Mark LaRochelle's study from a few years ago, basically looking at people at very, very high risk for overdose death, for fatal overdose. He looked at our mass PhD public health data warehouse, basically showing that of the 18,000 people who had interacted with ambulances or hospitals after a non-fatal overdose, that is, people extremely at high risk for having a subsequent fatal overdose because they had had a non-fatal one. He showed that only 3 out of 10 of them in the subsequent year received any amount of MOUD, even for a month, even basically a single script for buprenorphine, only 3 out of 10. But those who did had up to a 53% reduced mortality rate. And when I talk to students or residents, I feel like we're very hard pressed to find medications that are that effective, right? That they decrease your risk of dying by over half. And that was essentially true for methadone and buprenorphine both, not for Vivitrol, but the fact that they're so effective, yet only 3 out of 10 ended up getting them in this high risk population was really, I think, damning to doctors, broadly speaking, and healthcare providers. I like to show this graph too. It's a little bit complicated, but bear with me. This is from a college student's senior thesis, which I think is really, really cool. But what she was trying to do is she was trying to show 2 things. One is how often do people who are housed versus people who are homeless get medications in their addiction treatment plan? And the second thing she was trying to show was, did this differ by Medicaid expansion? So states that decided to expand expand Medicaid access under Obamacare versus not. So the first thing you'll see is that regardless of expansion states or non-expansion states, comparing homeless to housed individuals, homeless folks are much, much less likely to have medications in their addiction treatment plan. So if you're housed after the ACA and you're in an expansion state, almost half of the folks who basically were eligible for medications like buprenorphine or methadone got them, where about half of that, right, if you were homeless, got medications. Now, if you look on the right, a non-expansion state, so this obviously isn't true for Rhode Island or Massachusetts, but in the South, let's say, if you're homeless and in a non-expansion state, even after Medicaid expansion, you only had a 10% likelihood of having a medication on your addiction treatment plan. So you can see that, and that was 15%, so it increased if you were housed. But basically the idea being that not only does access to medications, right, according to this big database, vary significantly by Medicaid expansion versus not, but if you're housed or not, and if you're homeless, you're very, very unlikely to have medications on your treatment plan, which we know is even true in Massachusetts and even among our patients. So what are the barriers to opioid use disorder treatment among patients experiencing homelessness, people experiencing homelessness? Well, they're varied. They're individual, institutional, and policy factors, I would argue. And again, that student wrote a great paper, Natalie Swartz, about this, interviewing basically the patients that we were interested in getting onto treatment, patients at MassCast and patients at our shelters. I'm going to talk a little, and one of the things that she found, and I should have put a quote on there, but is that people, interestingly, at that time, there's a lot of work being put into ED and still into emergency department based interventions, basically being like, all these people are coming in after their overdoses and they're not getting on the buprenorphine and methadone. We need to get people on them there, which we're not arguing is false. However, what we found when we interviewed patients is that immediately after an overdose, when they've been reversed with Narcan, they report being very reluctant to talk about treatment. They are more interested in getting some more opioids relatively quickly, and so they felt like when we talked to them that the ED or even ambulance-based MOUD type talks are not going to be effective. What they did say is that at certain times in their life, they're sick and tired of being sick and tired. So there might be just a moment in their life when they come to the shelter, for example, where they're just done with the rest of it and want to start medication. So we knew that was the case in talking to our patients, and Natalie's study helped sort of bolster that. But basically what we were seeing initially, and I'm very proud of the family team for this, because at Healthcare for the Homeless, the family team sites were the first ones where we prescribed buprenorphine. But basically we'd see these families, these typically a single parent, mother or father with dependent children, who had to deal with childcare, school, trying to find work, transportation, because a lot of the family shelters are far outside the city, and addiction treatment. A lot of people, even who had previously been on methadone or buprenorphine when they were in their home neighborhoods, once they got to the shelter, it was just too much to manage. So after having enough of those conversations, after knowing that we weren't reaching people, we started a shelter-based buprenorphine program. It's kind of funny to look back at it, because we back in 2015 when we rolled it out, we felt like we had to have this very like strict protocol, and we had all these things. We required behavioral health visits, and we did all this stuff because shelter-based buprenorphine in 2015, not even Healthcare for the Homeless was doing it. So it felt like we had to have all these rules. But ultimately, it's evolved significantly since then. I think as buprenorphine provision in all settings has evolved away from like observed induction and all this stuff that we were doing back in the day. But we showed that there was decreased substance use in our first year's cohort of patients. We showed that we had no overdoses, which I think was important to document, because there was really a sense that people would misuse the buprenorphine, and so we shouldn't give it to them. And then we showed increased employment in our cohort. But basically, qualitatively, which was I think the main and important thrust of our study, was that people talked about the convenience of it. It was convenient. It was literally right down the hall, but they were also very helpful too. They could kind of recognize when things were tough, and always were supportive for that, and let you know that they were there. They never made you feel like you were any less of a person because of that. I also want to highlight this quote, which I love, because it really got at so many of the logistical barriers. People figuring out what to do with their kids if they're going in for methadone, figuring out what they had to do with their, as far as transportation to get to a methadone program that might be 2 hours away. So, well, I don't have to take mad buses and trains and be secluded around crazy people and other people that I don't want to be around and don't want to see. Getting at the way that methadone, and certainly methadone access from a family shelter, has barriers that we helped overcome by doing shelter-based BU. So, and I love this quote as well: the effect of shelter-based addiction treatment or opioid treatment on role in family. A majority described being able to be a better parent and be available for their children when we brought treatment to them rather than waiting for them to come to us. It supports my role in my family, because without the treatment, you really wouldn't be there for your kids. You'd be out on the street trying to get your next fix. So we ended up subsequently expanding SBOT as politically tolerated, right? Because every single shelter-based site that we're at through Healthcare for the Homeless, we're dealing with a partner, whether it's the city, whether it's the state, whether it's a private nonprofit that runs the shelter. But as tolerated, we pushed it out to all of our sites. We do transition folks out once they leave shelter and are housed, let's say. But what we still find, even in Massachusetts, is long wait lists in some communities to get onto buprenorphine, and a lot of hoops and barriers. So we do transitional visits, telehealth visits for a bit as well, until people transition out. And then we actually started at the adult sites later than the family team sites, but most of the adult sites are able to do this as well. Most recently, Pine Street Inn, which had resisted for a long time because they have a more of a sobriety type focus, but they have this year let us prescribe buprenorphine there. So I think that's important because, as you can see in this map, we have shelter sites, an outreach site, street team, mobile outreach van all over the city. And I think bringing treatment to people is important. One of the reasons that I think it's important, period, but because there's a lot of people that I've started that wouldn't have started if we waited for them to come to us. But we actually have this really high quality study that Danielle Fine and Travis Baggett and others from MGH did, but basically showing that at Healthcare for the Homeless, if you had your first OBAT encounter at a shelter or outreach site, your adjusted hazard ratio of dying was 0.58, meaning that you were like 40% less likely to die if you were started on these medications at an outreach site. Meaning, I think that we're catching really, really high risk people if we find them from the van or we find them at the shelter as opposed to our main building. Additional efforts to increase MOUD access. This could probably be a whole other talk, but just to, I know that, time constraints, we want to leave some time for questions, but this is slightly older. This is older data. It's after, I think, a year of operation, and now we're, I think, 3 years in of our Sublocade program at our main site. But basically, in the first year, we had started like 100 patients with 50 of them still on active treatment. The average length of treatment was 5 months, which is pretty good. And then they had given their 500th injection back in 2022 when I got this data from. And pros and cons, but that's another way in which we've expanded access. And then methadone, actually, Roundhouse, which we can bracket talking about, but and McGinnis, the plan, I don't know if it started yet, but is to apply, which is our main building, basically is to apply the 72-hour rule that Jess Taylor at BMC and other folks have sort of pioneered operating under, but to start people on methadone immediately, same day, and then titrate up for 3 days until they can get connected to a methadone program in the neighborhood. Okay, so that's the expanding MOUD treatment access piece. I'm happy to answer questions about that now. The next piece I'm going to talk about is some of the innovative harm reduction stuff we do at Healthcare for the Homeless, but I can pause for a second if anyone has any questions about this.
This is so great. Thank you. I have 2 questions, but I want to give folks in the room a chance to ask questions. Feel free to either unmute or put them in the chat. Any questions so far? Otherwise, I'll go ahead and ask. One question about Sublocade. For those in the room who are not treatment providers and don't know all the ins and outs between Suboxone and Sublocade, could you just explain like why a patient might be prescribed Sublocade versus Suboxone? What are the kind of pros and cons?
Yeah, I think there's like the long-acting injectable buprenorphine. Basically, the idea would be that in a lot of ways, logistically, it's just it is more convenient. You don't have to worry about having to take the films. The films themselves, a lot of people don't like, but you just don't have to worry about it every day. You can get the injection, and theoretically, on paper, for a month, you're good, and you just come back, get your injection again. Don't worry about it day to day. They're also from the carceral, sort of side of the way we approach substance use treatment. There's a sense of, okay, well, this can't be diverted. If these are people who are going to divert, then we're not giving them strips or pills that they could give away or sell. So, from let's say for folks who are thinking about on the correction side of wanting to, or having to start MOUD programs from that side, I think there's some sense of, okay, this is maybe something we're more interested in. But what we found actually in other papers separately is that it's not this magic bullet. One, for a lot of people, there was a sense that you had to start people who you could only really give it to people who are already on a stable dose of buprenorphine. You're not just starting it on people from scratch. But what we're finding is that it does have a peak and trough situation over the month, where there are times of the month when people actually need, or even throughout the month, will need buprenorphine strips on top of the coverage that you get from the injection. So that was a problem. And for whatever, there are injection site things that people don't like bumps and things that people get. And for whatever reason, it's not been the panacea that we thought. You might think that everyone will want to go to that, but it just hasn't been that magical thing. And Jake Morgan, for those of you who know him, I think Brandon, you might have been on that paper too, but basically, if you look at the administrative data, it's also not true that it's amazingly more, there's more retention on it. There's just not. It's just basically very similar. So it works for some people. It doesn't work for other people. A lot of people still have to get additional strips on top of the injection. So it's just not the panacea. But at the same time, the mantra I think with MOUD expansion is giving people all the options, because for that person it might be that Sublocade is better than bup, and so or than like sublingual bup or methadone. So we just want to make sure all options are available as many places as possible.
That's great. I remember there being so much excitement back at Hopkins in, I think, 2019 when it was prescribed to the first patient of the clinic I was in. So it's amazing to see that there's hard data on it now too. Carly.
Hi,
Oh,
sorry, sorry, I was late, I will admit, so you may have gone over this already, but well, first, that's incredible, the paper that you showed, like 40% reduction in death, or reduced death for those that were started in the shelter. That's amazing. But do you know, like, I have heard that in some systems where if somebody's in a shelter and they like have an overdose in the shelter, then they may be like kicked out and not allowed to come back. And I wonder if you encountered any of those, and like, how did that impact their treatment?
So that's a great question. So, and we just finished up a qualitative project at 4 shelters in Massachusetts, one in Worcester, one in Boston, one in Lowell, and one in Salem. And the goal was exactly that, to get at harm reduction related policies. So we interviewed 10 guests and 10 staff at basically each site. And we're currently going through all the transcripts to code them. But those are exactly the questions we were getting at. We're lucky. I'm luckier even than I kind of realized, because I don't know about Pine Street, but because I haven't practiced there, but my sense is there's a lot more of that attitude towards substance use. That is, if you were to use opioids at Pine, it would be like sayonara out the door. I'm at a BPHC run shelter, and there is a harm reduction focus, and they're doing a lot of good stuff. And so there's never the sense that if you were to overdose, we wouldn't have you back. And so they do absorb really high risk folks, maybe from other parts of the city. But we are trying to get at that question, because we don't know. We definitely know that what you're saying is true. There are going to be places where if you were to be caught with drugs or to use drugs, those shelters will no longer have you. But we know that it's on a broad spectrum. On the other hand, you have like the roundhouse type model that I will say Southampton Street Shelter on the second floor, they have like this friends floor model where you can leave and come back as much as you like. And there's a harm reduction focus to it. So there's a lot more of a sense of people might use and be intoxicated there. But we're trying to document that, basically. What are the spectrum of things that shelters do around substance use and overdose? So fingers crossed we'll have some sort of paper version of that available soon.
Great. Well, I look forward to seeing those.
Yeah.
Are there any other questions? Right.
So yeah. One thing I'll say about that's interesting is that while one of the things we tried to get at the interviews was like things that are policies that aren't like explicitly about harm reduction, but have a role either positive or negative around substance use and do affect harm reduction like broadly. Is that initially when I started, well, I think it's sort of still discretionarily in place, but basically we used to have a lot of overdoses. We have fewer now. There's a lot of things around that, but when people would have an overdose and we responded, the policy of the shelter was that it was such a bad policy, was that the person who overdosed was required to go to the emergency department, and if they refused, they were kicked out to the street for the day. Like they could come back the next day, but the idea was like acutely after an overdose, if they were Narcan, they had to either get papers from the hospital or stay on the street, which is such a dangerous policy, right? And it further stigmatized and made people hide their use in a way that was dangerous for them and not helpful for us. You know, it's tough because while very rare, there are people who die of overdose in the shelter. So we don't quite have the sobering space type capacity in the shelter that we should in terms of watching people, which I'll talk about actually, like we do at Healthcare for the Homeless. So ideally, I think it would be okay for people to stay and just have a little bit of a watchful eye over them. We just don't have that infrastructure in place. So it is from the shelter staff's perspective, who are not medical, you sort of see what they're trying to do, but that sort of policy, while it is meant to help people get the help that we would like them to get, it potentially just sent people out on the street who were at risk for then overdosing and dying completely alone in an alley. So, okay, the getting at the harm reduction piece a little bit more. Again, this is all something that is all well known to you. We often like to think about people when they're not using, but Jesse talks about us engaging people who are in active use. And one way to do this is applying the harm reduction lens. Harm reduction, there are many definitions, but the one that we're using here refers to a range of services and policies that lessen the adverse consequences of drug use and protect public health. Unlike approaches that insist that people stop using drugs, harm reduction acknowledges that many people are not willing or able to abstain, and that abstinence should not be a precondition for help. And this slide also has like a set of practices that align with that. The one I'm going to talk about is the supportive place for observation and treatment. In light of the fact that Rhode Island is about to roll out an overdose prevention center, this maybe is less like groundbreaking or revolutionary than it was for us a few years ago. But basically, in a state like Massachusetts, in a state like most states, where OPCs are not allowed and no one is trying to do it under the table. Spot was an attempt to do everything within the law, except just short of what could be described as an overdose prevention center or safe consumption site or safe injection facility at the time. So to prevent fatal overdoses, more effectively connect high-risk individuals with treatment, and just tackle stigma. So basically, like this picture shows, let's say that person on the right in the hat is sedated and is leaning on their friend for help. Rather than just stay on the ground like that on a city street like in Boston, they would be able to pick up the patient, sort of support them and walk them over to Spot. So this is Spot. It's a room at our main site, and it offers medical monitoring, treatment of overdose symptoms, counseling about safer injection techniques, and connection to primary care, behavioral health, and addiction treatment, which are all in the same building, and then a place from which we distributed naloxone. There's a nurse there basically, and then potential for the peer support, and then potential for MD and PPA if needed. This technical stuff I think is less interesting. What I did find interesting was the media coverage. There's some media that were like fine and good. I love this picture of Casey Leone. And it actually points to one thing they did that was really cool, modeled after the studies that they did in Vancouver of the safe injection facilities. But they went around and they counted the number of discarded needles they found in the neighborhood around Healthcare for the Homeless after implementation of Spot. What I think is interesting though, and what we're dealing with, and we always deal with, is the type of coverage we got in the bottom right, which is like saying the new heroin clinic offers watchful eye on Boston's methadone mile. Like all of those things are wrong, but these are the things that are in the media around what we're trying to do. There was a lot of neighborhood resistance to what we were doing. But we were in Spot dealing with a very high risk cohort. There was a cocktail, which I think is less of like or maybe it's just so widely used that it's not really talked about as much. The overdose syndrome was really interesting. We had a lot of interesting findings, like a lot of bradycardia and hypotension. I think the clonidine sort of contributed to that. But one of the things that Jesse talks really eloquently about is engaging patient voice in designing Spot. There are a lot of unique things that she ended up doing in building the program that patients told her to do that she wouldn't have thought of otherwise. One is not taking patients, so allowing people to be there whether or not they shared their names. Two is not connecting the spot medical record to the rest of the medical record. Folks didn't want necessarily that they had an overdose to get to their other providers, um, and a lot of other things. For those who care. I mean, the blood pressures would get very low in patients that you just sort of watched and didn't send to the ED, and they got better and it was fine. Oh, and heart rates were very low too. Okay. And then as one of the nurses, what they said is that, and I think this is a sort of thing that you'll get at your OPC, but I think what struck me the most is a gratitude just to get out of that environment, even for a little while, to get off the street and be cared for. I mean, so many of our participants don't have anyone who's caring for them. Actually, in that vein, I'm gonna go to this slide, which is that Spot is great. As you saw, it's one room and relatively small. We should have spots at all of our shelters all across the city. But I'm going to tell a quick story because this gets at some of the reason that I do some of this advocacy, and why I'm so gratified that you all have been able to do this in Rhode Island. But I had written this piece after we were called to respond to an overdose at Mass Cass, which is right in front of Southampton Street Shelter. So in the summer of 2019, um, there was a lot of there were a lot of overdoses basically in the space in front of the shelter, and routinely 1 to 19 times a day, because we documented these numbers, we would get called to the front of the shelter, and the staff of the shelter would say overdose out front. We'd grab our oxygen tank and our bag of like supplies and run out. And this particular case crystallized things for me in a way that helped me reframe in my mind, even though I'd already been there for years, what was going on outside. But we got to a patient and he'd overdosed. His O2 sat was really low. He was looking very blue. While we started sort of our medical response, his friend who was there said he just got out of prison. That's why he overdosed. And then the woman next to him was like, "Oh, I gave him a dose of Narcan already." And then we like did our little response. I think he might have required a second dose of Narcan. We're waiting for the ambulance, and then and this is something he had in his jacket like a packet of needles from A-Hope, like basically clean new syringes that he'd used to inject. And we responded to the overdose. He was very, this is not always the case, but he was, and not that it matters, but he was very apologetic. Interestingly, he was like, "I'm so sorry. I'm so sorry." He ended up going in the ambulance to the emergency room. He eventually started on Suboxone, and I prescribed him on Suboxone for a while. But anyway, all that before that, in the moment as I was walking away from the encampment, right where he'd injected, where someone had given Narcan, someone knew his history well enough to help inform, what was going on, and someone called for help when he needed it. I realized that what folks had done in that encampment, Mass Cass, that's so vilified, was that they had established a safer consumption space. They were not using alone. They were never using alone. They all had Narcan and knew extremely well how to use it. They had clean supplies. They were going to or interacting with the A-Hope outreach workers to get the supplies that they would need to not contract infectious diseases or whatever it might be. And they knew when to call to help because they were never using alone. So anyway, when I sort of wrapped my head around the fact that what they had done was a thing that the government had refused to do and our clinics, our medical system had refused to do, because this is back in 2019, I was like, damn, like we need to respect them enough to do the things they're trying to do for themselves out on the street, alone. So anyway, so that gets at this picture, which was in the Globe, in that article I mentioned, and what you'll often see at Mass Cass. I mean, obviously they've swept it up now, but what you would see is people just coming by to like take cell phone videos to post on Facebook, and post about how evil and awful this place was by posting pictures like this. But what I wanted to do is sort of reframe. This is less of an audience where that's important, but this is more so, I think, helpful when you talk to students or residents or docs who are not doing this sort of work all the time. But I'd love to hear what folks maybe see. You may have to zoom in or squint a little bit, but that are things that are in this picture that are actually good and helpful and positive and affirming things that we want to praise. So if anyone wants to share either in the chat or muting yourself, unmuting yourself. Any good positive things you see in this picture?
Well,
oh,
oh no, go ahead, go ahead.
well, two things that I kind of see. One, obviously, you kind of mentioned that someone's, I can't tell if the observer has used, but he seems to be alert. And then second, there's something on a brick that's like in the
Yes.
far corner that it looks like it, maybe he washed with soap and water. I don't see anything, but maybe it's alcohol, maybe it's something to clean the site.
Perfect. Love it. Yeah, that's one of the, I think, sterile water bottles from I hope, I'm pretty sure. And yes, exactly. He's not using alone. Someone's watching him.
Yeah.
Perfect. Excellent. Those are two good things. There's at least a third thing, and probably more things that I don't even see, but if you kind of squint and look on his jacket arm, there's a little Band-Aid. So he's thinking
Yeah.
about wound care. So absolutely. I think reframing these things and what you're seeing is so important. And that's why I wrote that piece that ended up being in Annals. It was a hope to like reframe what was going on in the encampment as positive. I'll talk a little bit more about that. I mean, basically people will see this and see like this the root of all evil in the city as scenes like this, not respecting the sort of dignity and wisdom of the people who are using. In Boston, they passed in the fall this health and safety inspired, quote unquote, health and safety inspired police ordinance that allowed for the police to take down tent encampments, tents, period. And there are these little like sort of, nods, not even nods, not isn't the word, like very cynical concessions to public health, which is that, they had to make an offer of shelter. So they had to let the person know there was a shelter they could go to. And theoretically, they're saying they're going to store the belongings. I have no faith that any of that happened in a logistically meaningful way. But what we presented many times was all the data, both quantitative and qualitative, that shows that when you interrupt an encampment, you actually increase the risk of overdose death. There's a great modeling study that Josh Barocas and colleagues out of Colorado did that basically showed that what we knew to be the case, which is that when you get rid of all these protective things and you scatter people to all the winds, you're not going to be able to get supplies to them. You're not going to be able to get narc into them. They're not going to be able to watch over each other, and they're gonna die. Frankly, I mean, I remember the day after one of the early sweeps back in 2019. The next day, walking back to the shelter-based clinic, walking in, and the ambulance driver saying, "We got a call about an overdose, but we just don't know where it is." Back before the sweep, we knew exactly where to come. Now this guy is overdosed somewhere in an alley, and we just like cannot find them. So that is 100%, what is going on. So what else do I have on here? I think we can. Yeah, okay. I'm not going to talk about that because I think it's less relevant. This is about safe injection facilities, but supervised injection facilities. I didn't have time to put together slides about this, but basically, there's a Josh's study that shows that you have increased overdose deaths after encampment sweeps. We did a qualitative study of folks who are swept up and showed two things. One, everyone felt less safe. Everyone felt like they had done their best to build a community where safety, privacy, and those things were prioritized. They could watch over each other and try to prevent fatal overdoses. Whereas post-sweep, people, and again, we interviewed people who were swept up but did not go into harm reduction housing sites, and those who were, but those who were not in one of the harm reduction shelters all reported that they felt that they were at increased risk of physical assault, sexual assault, and overdose. But Boston, after the sweep in 2022, implemented these harm reduction housing sites. So some of you are familiar with Roundhouse, the Envision Hotel, the little cottages. All of the people who we interviewed at those places felt like those places supported their health and safety and recovery. There are a couple, and dignity, and there are a couple things. I wish I had a slide. I just didn't think to put this together for this, but I think under the vision of Monica Burrell, who used to be the chief medical officer at Healthcare for the Homeless and was then the commissioner of public health for the state, they developed these very innovative shelter models. Now, the problem with a place like Southampton Street or Pine Street had been that you can't bring in substance use. You can't bring in your substances, but you can't bring in any items related to substance use. You can't bring in syringes. You can't bring in any of the clean supplies and things that they would give you from AHOPE. So people would be stashing them like behind fences to get into the shelter. Because the shelter is so full, it's been 100 people over capacity for the past 6 months, which is why this idea of offering people shelter when you sweep up their tent is completely farcical. 100 people over capacity. So if you have to come in by 4 p.m. to get a bed. As soon as you come in, you're not allowed to leave. If you leave, your bed is given to somebody else. So for someone to have to come in by 4 p.m. and then stay till the next morning if they're going to get a bed, and someone in the meantime would need to use, forget even want to use, the shelter, that rule was not really practical. And just baseline, they don't have enough lockers for people in the shelter. So people's stuff would get stolen, including their prescribed medications all the time. All that to say is there are a lot of reasons that people did not want to stay in traditional shelter. The harm reduction housing sites have a lot of features that recognize that. One, for example, they all had locked private spaces. Two, you were able to stay with a opposite gender partner, which was not the case, obviously, in the gendered shelters in Boston. And you could come and go as you pleased. So you could come back. They had harm reduction techs they hired to watch over folks and do safety checks, but they had a lot of things in place to promote the safety promoting things that people had put in place at the encampments. And people reported doing much, much better in those settings. So anyway, that is a little bit of findings and process. We do have an initial qual paper, and there's Josh's paper. And then I'm working with Tracy Green and a team from Brandeis to do more rigorous work around those novel harm reduction oriented shelters. But the city has started a retreat from those already. And basically, as they do sweeps now, no one's offered anything, which is really challenging and ascientific. But we continue to fight the good fight as best we can. So I'm going to stop there because we have about 10 minutes and allow people to ask questions. But yes, all that is great.